What I want for you is choices, information, things that you can trust, things that you can apply, and things that can be monitored actively. This is the heart of the matter. It is presenting to you an alternative. Now, how do we deliver on this promise? I'm going to share with you why I believe that we have developed the best way to evaluate and respond to either prostate cancer or elevated PSA with a high risk of cancer being present. It starts by reflecting upon the state of conventional treatment. Despite well-intended therapies, and despite the intuitive logic of cutting out a prostate gland that may have abnormalities within it or irradiating that gland, the outcomes have been profoundly disappointing. In fact, it's fair to say that the only thing that conventional therapy can guarantee is pain and hardship. The studies are in, and the results regarding survival from prostate cancer are sad. There's no huge difference thus far documented between aggressive treatment and doing nothing. Now, I don't propose that you do nothing. I propose that you gather information. And yes, you can consider conventional treatment, but it's not your only path. I'm going to describe to you an alternative approach intellectual medicine has developed. This has required decades of observational clinical assessments, deep research regarding the history of prostate cancer and the current state of its condition and treatment, as well as clinical application. So what makes the intellectual medicine approach different from everything else you're going to read on the internet? It is not a one-person response to a phenomenon. Billy Bob beat cancer eating kumquats. Okay, I get it. It's compelling. The difference is that this is observational over many years. We've been doing this for 10 years, watching outcomes. It's critical for me, for us, to make sure that the information we share is credible because it will guide you in your health decisions, as well it should. So go back to my other podcast. I can summarize them for you thusly. Taking out prostate glands and irradiating them, guaranteed harm. No difference regarding survival from prostate cancer after 15 years in many of the best studies. Now, it's not to say that the treatments are without any merit. It's just that the evidence of benefit is weak, but guaranteed harm. So let's go back to the basics of medicine, right? First, do no harm. If you're going to subject me, my patients, you, to a surgical procedure, a biopsy, guaranteed harm. There's got to be a big upside. Now think about it, folks, rationally. What other form of cancer do you stick a needle in it, identify cancer cells, and then say, well, we're just going to keep sticking needles in it every so often? It begs credibility. I understand the dilemma. Urologists have limited capabilities. They can do biopsies, they can do surgery, but stepping outside of that, looking at it from the outside in, that requires a different perspective, the one that we bring to it. So surgery, radiation, needle biopsies, and for God's sakes, men, do not let them castrate you. Do you know androgen deprivation therapy, which is castration, chemical castration, is considered cruel and unusual punishment in the judicial system. If you're a criminal, they wouldn't do this to you. Why? Because the outcome is horrible. So now we have a need, you and I. Great, these conventional therapies are bad for me. They have harm. Castration, it's a horrible idea. It is sometimes applied in a setting where the prostate cancer has been treated, but the PSA continues to rise. They call this a chemical relapse. That's nonsense. A PSA rising does not necessarily mean that the cancer is progressing. However, they use that false marker as a justification for castration. The PSA number might get better, but you're going to feel horrible. You're going to get weak, tired, horrible things happen. And ultimately, there's no guarantee of benefit. Guaranteed harm, no guarantee of benefit. So how can you proceed? What do I propose as an alternative? First, we actually do not need to make a tissue diagnosis, people. We don't need to stick a needle in to make rational judgments about how to proceed. We want our vitality. We want our health. We want to create an internal environment that is inhospitable toward cancer. We want those cancer cells to stay in the prostate gland. They're not really cancer cells. These are atypical dormant cells, ADC. They're there, they're sleeping, let them be. The majority of men past 90 have ADCs in the gland. Cadaveric studies have demonstrated that. So ironically, my goal, your goal, it should be to die with prostate cancer cells or these atypical dormant cells in our gland. They cannot kill you, folks, if they stay in the gland. Of course, here's the dilemma. There's no test available that can absolutely declare whether they're still in the gland or not. Not a biopsy, nothing. Now, some imaging studies can declare if it's metastasized. That's true. But at a cellular level, when it's in the gland, that's what we're interested in. So no biopsies. Hey, if you've had biopsies, I understand. Don't panic. You can change your direction. If you're in the middle of getting radiation therapy, if you're scheduled for a prostatectomy, I encourage you to pause and reflect and consider alternatives, right? These are not going to be funneled through conventional medicine. There's something called a treatment bias that has petrified thought and progress in the prostate cancer field. The treatment bias goes like this. The incidence of death from prostate cancer in the first 5 years is almost zero. Early stage prostate cancer has a 100% survival after 5 years. Now, stow that in your memory. You go to the doc, you have an elevated PSA, they do a biopsy, they say, oh, you have cancer cells, they take the gland out. 5 years later, you're still alive. You tend to give credit to the surgery as the reason, when in fact, it was a coincidence. You give credit to the surgery because you've suffered leaking urine, erectile difficulty, the surgery itself. You have to believe that it was worth it. And the surgeon has to believe he saved your life. Every time I see a celebrity or another individual saying, thank God they caught this cancer, they saved my life, it defies the evidence. But emotionally, psychologically, it's powerful. I get it. And it's for that reason that these treatments have persisted. I think it's for that reason, and also the lack of alternatives. Well, we're about to fix the second part of the problem, the lack of alternatives. The psychological part, that is for you to reflect upon. I'll summarize it as the philosophy of regret. You go through surgery, they whack your prostate gland. You're feeling pretty good, you're leaking urine, maybe erections aren't good. The PSA goes up, they give you castration therapy. Now you're really suffering, right? Fatigue, mental fog, increased rate of heart disease and dementia. Then the cancer comes back anyhow, and you say, damn, what'd I do that for? Now let's flip it around. You don't do any of that. You follow the intellectual medicine pathway. No biopsy, no surgery, nothing. There's no guarantee, folks, that the outcome will be as we hope. What we know for sure is that you're not going to suffer surgical harm. You're not going to suffer castration. Suppose, however, it's 10 years, it's 15 years down the road, and you're doing the intellectual medicine pathway and the cancer extends. You have to be at peace with your decision, knowing that you made the best decision you could based on strong evidence and benefit, and that this was just your fate. It's a hard thing to decide. There are just no guarantees. All right, now we have our base. You guys can start to reflect the psychological part. What about this non-biopsy approach? At Intellectual Medicine, we've established 3 stages of prostate cancer risk I'm going to call it risk because there's no tissue diagnosis required. The three things we look at, there are now biometrics and there are imaging studies that can give a real good picture as to your risk of dying from prostate cancer or of your risk for having it progress or extend. The three things that we look at, one of them is a PSA, the other one is a PHI, a prostate health index, and the third is a prostate MRI, an MRI of the prostate gland. If the PSA, the stage 1, if a PSA is less than 20, the prostate health index, the PHI, is less than 55, and the MRI of the prostate shows a PI-RADS of 0 to 3. If these three criteria are met, we consider this a stage 1 presentation. Low risk, no biopsy is done, no surgical treatment is recommended, but rather we implement the intellectual medicine pathway. It consists of lifestyle modification. It consists of nutritional focus. It consists of supplement use and repurposed drug therapy. Today, I'm going to focus on the repurposed drug therapy. It is one of the most important elements of the treatment pathway. In future podcasts, we'll expand upon nutrition and supplement. The objective is to keep this cancer in the gland. The benefit of this approach, you get a global enhancement. The things that are recommended to help make your body less hospitable toward prostate cancer have collateral benefit regarding any other form of cancer as well. So you get a global enhancement. So here's your stage 1, the PSA less than 20, the PHI less than 55, and the MRI of the prostate is a PI-RADS of 0 to 3. These studies are inexpensive. They're generally insurance covered. So this can be done in a sustainable manner. So this is what matters to me as we do this research. Number 1, is it safe? The supplements and the treatments have to be safe. We don't want to hurt people who are in good health. Well, we don't want to hurt people, period. Number 2, what's the evidence of benefit? The levels are relevant. Level 1 evidence, in vitro. These are Petri dishes. We see the drug working against cancer cells. That's nice. The next level, called xenographic models in mice typically, you take human prostate cancer, you give it to a mouse. Yeah, the mouse isn't happy about that, but we need the study. And then you see how the drug works in a mammal. That's encouraging if you see favorable effect. The next level, level 3, case studies, clinical observation, actually applying it to humans and observing the response. Helpful, not proof, but helpful. And then the 4th level, and these are formal controlled studies. Level 4 evidence is rare. These are generic drugs. Nobody's paying for these studies. We're up against a multi-billion-dollar industry, people. The emphasis is on early diagnosis in conventional medicine so they can justify biopsies and interventions, none of which I recommend. Ironically, early diagnosis in the form of testing that leads to biopsy, I believe, can be counterproductive, can cause harm. We can do biometrics, we can do imaging, no biopsy needed. So here's a recommendation. Stage 1, repurposed drugs. Metformin, love this drug. Generic, inexpensive, lowers blood sugar, has anti-cancer attributes, cost a couple of bucks a month. The other drug, repurposed, sirolimus, another agent that I love for my patients. It has intrinsic anti-aging value. It interferes with and delays cellular degradation, and it supports mitochondrial vitality. The mitochondria are the organelles within cells that are felt to be the origin of most cancers. Repurposed drug. These drugs are applied for other purposes. At low dose, once a week, sirolimus has positive effects on human health. At high dose, if you read these drugs, if you look them up, you'll see that it's an immunosuppressant, but that's not how it's applied. Doxycycline, yes, the antibiotic. Low dose. At a low dose, it does not alter bacterial balance in the gut. It doesn't really function as an antibiotic, but rather takes advantage of its properties that interfere with stem cells. These are the motherships that spit out little baby cancer cells. Very nice agent. Another drug, naltrexone. You look it up. It's a drug used to block endorphin receptors so opioid addicts don't get euphoric from the drug. It's supposed to help them. However, at low dose, it has a paradoxical effect. It can reduce inflammation. It can reduce chronic pain. We use this in fibromyalgia, chronic arthritic pain, and it's correlated with benefits regarding cancer. It is felt to interfere with mesenchymal extension, one of the vehicles cancer cells use to move outside and create metastatic lesions. Remember, we want to keep it in the gland. Atorvastatin. Yes, I know people. We're generally not enthusiastic about statin drugs in the functional medicine world. However, when combined with the metformin, the studies regarding its potential value toward prostate and other forms of cancer are very encouraging. So I consider this worth doing. How about reducing carcinogens? Valuable. Hey, if you live next door to Chernobyl, you'd probably move because proximity to a carcinogen increases its risk to you. How about if the carcinogen is in your body? Yeah, and I'm talking about cadmium, arsenic, lead. These are industrial byproducts that pollute the earth. They get in our water, in the dirt, they're in your food. You can't avoid them, but we can help remove them. There's a prescription drug called DMSA, dimercaptylsuccinic acid. The intellectual medicine protocol calls for twice a year a 4-week detoxification cycle, lowering those carcinogenic metals. Don't sit there in a soup of carcinogens. You can modify it. So those are the big pieces of stage 1. What do they have in common? Enormous safety. Generic drugs. I love generic drugs. They've been around forever. Their warts have been exposed. They're cheap. They're generally much safer, in my opinion, than new drugs, which haven't revealed their true characteristics yet. Oh, by the way, metformin has been utilized in anti-aging centers for its anti-aging value. DMSA, when you lower toxic metal, including lead, it lowers risk factors for heart disease and dementia. You're getting collateral benefit as opposed to collateral harm when you go in conventional treatment pathway. Then every 3 months, we're going to monitor the PSA and the prostate health index, the PHI. Inexpensive blood test, take a snapshot, things are going well, you rock on. You can do this indefinitely, which I encourage. Global benefit. The next stage, stage 2. Suppose your PSA is greater than 20. The PHI, the prostate health index, is greater than 55. Or you have a PIRADS greater than 3. It's a 4 or a 5. It's a higher risk environment. Still asymptomatic. Nothing in the body, nothing in the bones. It's all in the gland. Here we add a couple of other wrinkles. One of them is subcutaneous mistletoe, self-administered injections. Mistletoe, we use Viscum Molly. There are different types of mistletoe. Inexpensive, safe. It is an immunologic enhancer. It stimulates natural immune system that helps your body fight cancer in general. In this case, of course, looking for prostate. In Germany, this is a primary means of anti-cancer therapy, one of their most popular functional alternative approaches. So I like this treatment. The other one that we consider adding at this point is ivermectin at 12 milligrams once a week. It's important, folks, that you have guidance and you have a doctor, a nurse practitioner, somebody skilled monitoring this. We'll provide that to you because you don't want to go it alone. Harm can happen. In particular, I'm going to do a segue. Do not use phendimetrazine or Fen-Ben. These drugs, the antihelmintic, are used for animals and has potential liver toxicity. The dose is unknown. The research regarding anti-cancer is preliminary, has some potential merit, but it's way too early. It's way too risky. You don't need it. Remember, stage 1, stage 2. prostate cancer in the gland, emphasis on safety, emphasis on your health, antihelmintic drugs, potential liver toxicity, significant expense. Yeah, you can get it. I know you can get it on the dark web. You get on the, do not do that, people. There are better ways. Just because somebody is telling you, hey, I went on it and my cancer is, don't believe it. I already told you that there's a long delay with regard to prostate cancer. We can't trust affirmations of individuals as being credible enough to justify full treatment protocol. We must rely upon deeper research, broader experience collectively, as opposed to just one case. So I don't like that at all for the reasons that I shared. Well, how about if things progress, or if they've already progressed? You've got prostate cancer that has gone to other organs or to the bone. This is stage 3. Stage 3 is characterized by a positive imaging study, a bone scan, or a PSMA, prostate-specific membrane antigen PET scan, showing lesions in the other organs or in the bone. First, do not despair. The cancer can still be stifled. Prostate cancer is vulnerable. Prostate cancer moves slowly. The emphasis should always be on your vitality, which is why I do not advocate castration therapy ever. There's one caveat I'll share with you, but certainly not at this stage. Castration therapy will not cure the cancer. There is little evidence that it will extend your life, but it absolutely will make you feel horrible. The only place where I would consider it for my patients is with compelling symptoms. You can't pee because it's fully blocked, or you're having bone pain that's excruciating. Okay, these are end-stage events. In the functional world, I would consider at this point, with guidance from your oncologist, if you have stage 3 prostate cancer outside the gland, you're going to need an oncologist to work with you. Although I don't advocate much in the way of conventional medicine, there are things that oncology and conventional medicine can offer you that are valuable. Specifically, if you have cancer in the bone, it's at risk of fracturing. You can use targeted radiation to help strengthen the bone. So yes, work with your oncologist at this point, but no radiation to the gland, no surgery, no biopsies. It's really even more fruitless at this point. Albendazole is a consideration. It is an antihelmintic. It's approved for human use, and it may have value at this stage of prostate cancer when added to the other things that I've described, requiring physician supervision and monitoring. So there's always a path forward, men. There is always the ability to avoid biopsy, surgery, and radiation. You do not need to be passive and idle. The choice is not between these aggressive treatments that cause harm and nothing. That's a false choice. The things that we have developed in intellectual medicine are not proven to make you live longer. They do not cure prostate cancer, but there's abundant evidence supporting the possibility of benefit with absence of harm. That's what we want. In the world of medicine, in the world of life and death, there are no guarantees. What I want for you is choices, information, balanced information, credible information, things that you can trust, things that you can apply, and things that can be monitored actively. This is not just a fire and forget approach. It's an ability to monitor. Yes, we'll talk about supplements. I have to do it some other time. It's its own whole topic. Yes, we're going to talk about nutrition and lifestyle. Those things matter. I'm going to guess you're already doing a lot of them, and I will summarize those for you at another time. But this is the heart of the matter. It is presenting to you an alternative. Now, how do we deliver on this promise? Intellectual medicine is busily building a national infrastructure so that you'll be able to access this treatment pathway wherever you are in the country. It's going to take us some time. If you let us know what state you're in, we can let you know where we are in that process. I am committed to this. I think it's important for men's health. I want you to have choices. And there are not too many outlets that can deliver, because the things that I offer, the things that we have developed, are clearly outside of the mainstream of medicine. It is not reasonable to expect your oncologist or your urologist or even your insurance-based family doc to be comfortable with this approach. However, we'll be glad to share this information so that you can balance all your decisions. So it's coming soon. The book will be coming out soon. I appreciate your comments. I know that this is, in some ways, disturbing information. In a good way, it's giving you a breath of fresh air. It's giving you credible options. Live vitally. Do not sacrifice your vitality in a false belief that you will ward off death from prostate cancer. What do most men with prostate cancer die from? Answer: heart disease. Prostate cancer treatment can increase dementia risk. Mark me absent. I'll take my chances. Vitality always. All right. Thanks for the listen, folks, and encourage you to stay connected. More information will be forthcoming. And live well, live vitally. Fight prostate cancer like a man. Do not let them castrate you. All right. We'll talk soon.